Firstly, I must say you guys have insane amount of energy. Some 10 hours of academics have happened with some 30 minutes of break only. And you are still listening so keenly. A lot of what I'm going to say has already been said. So I'm just going to go quickly only to the parts where I'm going to talk about what we are trying to publish. It's still not published as what we think should be the Indian ROP guidelines. I think all of us agree that PAR is there to stay. And if you let PAR just on its own, there are enough studies to show you that they are going to have a lot of cicatricial changes, retinal holes and retinal detachments. The dangers of PAR for long-term retinal sequelae are known for more than 2 decades now, even before the terminology was coined. Somehow in India, we are not very keen on giving a second injection, and still laser has not replaced anti-VEGF. I'm going to highlight 3 studies that came out of India. One was a sort of a survey, and the other one was indications, and the third one is a sort of a meta-analysis of 30 years of neurodevelopmental outcome, and finally our recommendation. So this was all the Indian ROP Society members just about 5 years ago, and that shows you the trend. Almost all of us are going to give both injections, both eyes on the same day. Most of us prefer bevacizumab to ranibizumab for the reasons just discussed. We also see much lesser recurrences and much later recurrences that gives us a chance to follow up these babies for better vascularization. And that's basically the outcome of this survey. The narrative where we looked at different scenarios, this paper was more a practical assessment than theory. And summarizing those, we tend to give anti-VEGF only for aggressive ROP. We don't give it routinely for type 1 ROP. So in India, we are not giving it for stage 3 with plus or stage 2 with plus if it's in zone 2. As soon as it's zone 2 disease, laser is our monotherapy. It has more than 95% success in our hands. And I'm talking about the whole country in general, 97, 98 in some places. We don't see many recurrences at all after laser, especially if it's done well. So these are our indications. No access to laser happened during COVID, and lack of expertise also happened during COVID. But if you give anti-VEGF, we are urging them to follow up, to look for PAR, and to look for a long-term sequelae. Now, this is one document that's come from the neonatology group, and this is something we have to stand by now. This is the neonatologist saying that it should not be used for zone 2 disease. It actually says that. Should not. And then it also gives you a number here, 65 weeks at least they want us to follow up these babies. Okay, now how much evidence is there in this neonatology? It's a different matter, but this is a professional body giving ophthalmologists some sort of thing to work on. A lot of these cases I'd actually shown in the morning, but I'm just going to show you this one case. This was treated elsewhere, first injected and then incompletely lasered. Now this is the whole concept of incompletely lasered, and this is a time-lapse video which is not playing. Okay, let it be. So this is a year and a half. Let's hope this plays. You can see that this is a one-eyed child now. One eye has already gone into a 5B, 5C. I'm sorry. And this eye looks good. It's been injected by somebody, but not lasered. The child is 16 months old. Comes to us for an opinion. And I hope this plays. Okay, so I'm not going to play as well. Okay, so this one basically showed that there was 4 disc diameters of peripheral avascular retina that would have been missed clinically that we picked up on angiography. These are occlusive types of aggressive ROP, which almost mimic vasculitis. In India, we unfortunately see a lot of this. They do very well, and angiogram picks it up, does extremely well after laser. I showed this case in the morning, so I'm going to skip. What I want to go into is that, in ranibizumab, the recurrences are happening much earlier and much more posterior. And these are the ones that show some sort of an atypical occlusion as well. Even though they do extremely well right in the beginning, somehow the recurrences or the failure to treatment is much more in IVR than IVB. And look at this, innocuous looking blood vessels growing 6 weeks after the drug. But then 1 week later, just 1 week, if you had missed this baby, it would have already gone into a stage 3 with vitreous hemorrhage. Therefore, all of this real world experience that's coming out of India has prompted us to sort of make our own guidelines. And this is when you want to use the angiogram, do the laser, and then repeat the angiogram to see if there's still a notch that you need to go back and treat. Now, here we are not recommending that you do angiogram after anti-VEGF. That will be foolish for us to do it because there are very few centers who have it right now, even though the Neo camera has it. But it's going to be, if you have it, do it. It's a great idea. So this is unpublished. So this is going to see some change, which we are hoping to publish it in either the Indian Journal or the Asia Pacific, because that's our target audience. So let me break this down. Depending on the drug, our follow-up would change. So if you're using bevacizumab, you want to screen these babies weekly after the injection for the first 4 weeks, and then 2 weekly after that. But in ranibizumab, since we are expecting the recurrence to happen much earlier, we're going to see them weekly for the first 6 to 8 weeks. So that's the difference. So for the first 2 months, you want to see them a little bit more closely. And then after that, you release them for every 2 weeks. Now we know 2 things will happen then, either a recurrence or a persistent avascular retina. In our hands, less than 20%, and I'm talking about the whole country now, less than 20% of them reach the ora serrata. So because we are probably giving 1/3 of the adult dose, maybe we're seeing great responses, but we're seeing a whole lot of PAR. Okay, so recurrences of PAR, obviously, if there is a recurrence, we would treat. I know Dr. Mariam showed that how much recurrence is good enough recurrence to do the treatment. We don't want to debate that. In India, if you debate that and the baby's lost to follow-up, ideally will come back like that eye I showed you in stage 5. We see a recurrence, we want to laser. Okay, and I think that's kind of where the ICROP is also going, that if you see a recurrence, they've in fact divided recurrences, vascular recurrence, ridge recurrence, and both. They've also said it could be in the primary location, a new location, or both. Now with 6 subtypes of recurrences, we don't want to be breaking our head there. So, and we are going to say that when there's a recurrence, do a laser, unless we think it's a failure to treat. So if right in zone half, and that's a new term that Indians are trying to coin now, a zone half is when the vessels have not even reached the fovea. So it's a posterior zone 1. You might have read that terminology in literature, and we're seeing a lot of that. We're seeing where the blood vessels have not even reached the edge of zone 1, it's zone half. In such cases, high likely that the drug will fail and the blood vessels will reach only zone 1. And at that time, maybe you make an exception of giving a second injection, but otherwise, no. All of us are going to be doing laser. Now, this small font here is when the persistent avascular retina. So how long will you follow up? And this is where the entire consensus is going. So we are saying that ideally the vessels should reach zone 2 anterior, or 48 to 52 weeks. And there's a rationale for why we've chosen all of this, but for paucity of time, we'll discuss it during dinner perhaps. Or 4.5 kgs, or no facility for general anesthesia, or parents not willing for follow-up, which I think is very important in our country, maybe in yours as well, because this is a social issue. So these 5 things we are going to look for, and how to score these 5, should we look for all 5, 2 out of 5, 3 out of 5? We will build that on that consensus. And finally, almost all of us are doing laser under topical anesthesia. If you have facility for GA, you can push that. And this is done by a couple of Europeans and then some Indian neonatologists looking at meta-analysis of 30 years of neurodevelopmental outcome. Unfortunately, what we'd like to believe is that it probably didn't have any effect. And I agree with Professor Ehab that how can such a small drug affecting the eye suddenly affect the brain? But unfortunately, the meta-analysis shows that there is a slightly higher chance of autism and cerebral palsy. And this can be protected if you did laser after anti-VEGF. Therefore, and therefore alone, these kind of things that come out from there, a second injection is probably not a good idea. And management of PAR is really important. For some reason, managing PAR regularizes the entire vascular growth, perhaps, and the eye, the retina is probably just an indication of what's going on in the brain, in the heart, and the kidney. It's that time of fovealization is probably the critical one. Yeah, I think I want to end there. Thank you.
Thank you.